Welcome everyone. Today we are going to discuss the bladder cancer scenarios for the Part 2 FRCS Urology exams. We have trainees who have kindly agreed to record the session so that it will be a good learning source for revision. Before going into the bladder cancer scenarios, by chance, if you are reading any other scenarios, if you have any other questions, you can ask. Any general questions, like for example, yesterday while discussing the female urology, we had questions on orchidopexy. Any general questions on any other topic?
Can I ask about if the patient had acute urinary retention and we inserted catheter, would you like to do BSA directly, or when when we can do BSA?
Okay. Number one, acute urinary retention itself will increase the PSA and will give you a false positive result. And if the patient had a catheter placed, again, catheterization or any instrumentation will further increase the PSA. So it is not advisable to do the PSA on the same sitting. PSA's half-life is only 24 to 48 hours. But in general, it is safe to leave at least 1 week gap. So PSA can be done in 1 week's time. But there is a slight deviation from this norm, which is when you're seeing the patient with acute retention, when you are placing the catheter, obviously you will do a DRE examination. If DRE is normal, or if it shows like a slight chance for prostate cancer, like firmness on one side and maybe a small nodule suspicious, something like that, you can wait for 1 week, as I said. But if it's an obvious prostate cancer, quite nodule or gland, possibly T3, possibly extra prostatic spread, something like that, then there is no point in waiting for 7 days. You should do the PSA straight away, because we are already expecting this patient's PSA to be in the region of 20 or above, like hundreds or 500s, etc. Those baseline PSA people, the catheterization or DRE or acute retention should not affect. So any patient with quite obvious prostate cancer during DRE, you can send the PSA in the same sitting. And if it comes like say 500, then you are sure that the catheterization is not the reason. There should be a definite prostate cancer going on in the background. DRE as such is not the problem. So if the patient is not in acute retention, just coming for low urinary tract symptom evaluation, you're doing a DRE, you can send the patient for prostate PSA straight away. Okay, got it?
Yes, thank you, doctor.
Good. Any other questions? Okay, if there are no other questions, we'll start straight away. As usual, we will stick all the classes to a maximum of 60 minutes, but we can do maximum number of classes as much as possible. So one of you are going to present, so please choose among yourself who is going to discuss the case. The scenario is a 68-year-old man. Yeah, you can present, okay? A 68-year-old man presented from his GP surgery for visible hematuria to your clinic. How are you going to investigate him?
Okay, me?
Yeah, go ahead.
I see the patient in my dedicated clinic and one-stop hematuria clinic. On arrival, cancer or urology nurse specialist see the patient. She get a brief history, examination, and urine dipstick and U&Es and CT urography. I'll see the patient. Afternoon, I'll get history, physical examination, further investigation. And the history, I'll get is it the hematuria visible and time onset and duration of the hematuria, any associated symptoms, lower urinary tracts or UTIs. I'll ask about risk factor, smoking, smoking age, and occupation. And then I'll ask about red flag, if there is fever, neurological symptoms, and I'll ask about surgery, and medical drug history. I'll ask about baseline sexual and bowel function. Then I'll proceed by examination. In the examination, I'll examine if the patient's pallor, if the blood pressure. I'll check abdomen for palpable bladder. Then check external genitalia if there is phimosis or meatal stenosis, hydrocele. Then digital rectal examination. There is consistency of the prostate, any nodularity, any abnormality. Then focus neurological examination. And then I'll check lab investigation. If the urine dipstick negative, and get consent from the patient, I'll do flexible cystoscope, check the urethra or bladder walls, meatal ureteric orifice. Then according to that, I'll collected all this information. I'll counsel the patient for further management.
Okay, good. That's well presented. Nice summary. This opening gambit, try to make it like 60 seconds or 1 minute maximum. You can go maybe like 80 seconds. So when you are free, talk to yourself with a watch clock. You should, the information is good. So you should be able to make it within 60 to 80 seconds. Okay. So that there is more time for the examiner to ask you some higher level questions. Your option of having something like a one-stop clinic where the patient will come in the morning, seen by the urology specialist nurse. They will do the bloods and CT scan, and you will be seeing in the afternoon for flexible cystoscopy. That's a good thing. It's not a bad thing, but it is not that prevalent even in UK for hematuria clinic. I'm not sure where you got it from there or whether it's in your country. If it's in your country, I really appreciate it. In UK, usually patient will walk into a hematuria clinic, which is led usually by a doctor, clinician, like urologist. And the doctor will go through the history, as you said. Patient will go for flexi. The CT scans will be ordered on the day, based upon whether it's visible hematuria or is there any findings in the flexi. And patient will have CT scans and further treatment will be arranged. So just be a little bit careful. If you are confident, you can say this is an international exam. So examiners were completely instructed that the candidates are not supposed to be completely aware of the UK protocols. So there may be some small deviation. If the examiners won't mind, you don't have to tell exactly what is happening in UK. Okay, that is one thing. So that's the difference between the international exams and our local exams. Other than that, examination, flexi, everything is fine. Do you know the role of urine cytology in these patients with visible hematuria?
Yes, we can request the urine cytology, but if there is a clear mass in a clear tumor in the CT scan or in cystoscopy, no need to proceed as it's a high price.
Okay. The concept is urine cytology is very useful for visible hematuria. The sensitivity is much more less for non-visible hematuria. You will be doing urine cytology before patient is having a plexi, so you won't have the information whether the patient has got lesion or not. So because once you add a plexi, then you will be using saline for irrigation, and then collecting urine cytology will be a waste of time because the urine will be very, very diluted. If at all, if you are doing urine cytology, it should be done before the flexible cystoscopy. The best answer is I will perform urine cytology for visible hematuria because the sensitivity and specificity are better, and I will avoid in non-visible hematuria. The other reason for not performing urine cytology is active visible hematuria. If the patient has active bleeding going on, again, the urine sample will be filled with RBCs that will make the efficiency of the cytology examination to pick the abnormal cells quite low. So again, if the patient has active visible hematuria, you can skip urine cytology. That's the answer. how will you improve your cystoscopy? Do you have any gadgets to improve the sensitivity or the tumor pickup in your flexible cystoscopy?
There is BDD, photodynamic detection. There's 5-aminolevulinic acid to get by tumor cells, change to porphyrin. This by urine blue light between 375 to 440, it changed to red. We can detect it more cancer by it. There is another way, narrow banding imaging.
So narrowbanding imaging, it depends upon which company of stack system you are using. There is also another method by name known as spectra. The spectra narrowband imaging are exactly the same. Again, by changing the filter in the lens, we are improving the depth perception, you are improving the vascularity perception. So you may identify flat lesions like CAS more better. So you can bring in the CAS. Okay. Your
Okay.
patient flexible cystoscopy shows a 2 centimeter lesion in the left posterior wall, just lateral to left ureteric orifice. List of the bladder is normal, prostate is bilobar occlusive, but no specific problems. Urethra is also normal. How are you going to proceed?
I'll proceed as tumor is diagnosed. I'll do further investigation, CT, thoracic abdomen, and pelvis after checking renal function. Then I'll discuss this case in MDT. Then I'll counsel the patient about, in the presence of cancer specialist nurse that there is a new diagnosis of a tumor. We need to remove it by TURBT. Risk of hematuria, pain, and perforation of the bladder. Then we will remove it. If he approved, then I listed him for TURBT.
The things you can add is you will be obviously arranging the CT scan. If the tumor is a bit larger in size, if you think there is a possibility of the high grade tumor, you can arrange a staging CT scan in the same sitting. So you can get CT scan of thorax, abdomen, and pelvis with contrast, which will also help us to image the kidneys and ureter, because there is a possibility of 1.2% upper tract TCC in the presence of the bladder tumor. But if there is no tumor, anyway, you'll be doing at least CT urogram. There is no real reason to involve the cancer specific maculae at this stage, because we can wait till you get the histology. Nothing wrong in it. If they are around, you can involve them. But in UK, because they are also quite busy with their own list of patients, we will usually wait for the histological proof. Say, for example, if it's a renal lesion found in CT scan, we need to involve the cancer nurses straight away. If it is a testicular lesion, which is quite suspicious, you are sending the patient for testicular tumor markers and ultrasound, you need to inform the cancer specific nurses straight away. If it is a bladder cancer with quite comorbid presentation, like possible bone metastasis, extensive bladder tumor, patient has bone pain, etc., and you suspect high evidence of metastasis, then there is a role for the cancer specialist straight away before histology. But if there is a solitary tumor, you have no major concerns, yes, it's a possible TCC, but you can hold on till you get the histology. Okay, but the answers are not wrong, but think in that way. And at this point, you should bring the BOWS information leaflet, which is easily available in bows.org.uk website. It has got TURBT information leaflet. Apart from verbally explaining, you can also give this paper so that the patient will go through what he's going to have on the day when he's coming procedure. So this patient, you have consented, you're on the day of the surgery, so patient is presenting to the theater. How are you going to proceed?
WHO checklist, and anesthetize the patient. They give antibiotics, drubbing. I'll do bilateral manual examination. Then inserted the cystoscope to check urethra and bladder walls, to check size, tumor, kind of tumor, how number of the tumor. Then I'll inserted the resectoscope after dilatation of the urethra. Then I'll do remove it by nephrectomated. Then all visible tumor. Then get biopsy from the bed and from the edge of the tumor. Then I'll do birural polar control bleeding. Then if there is any suspicious area, I'll get a biopsy. Then if there is any carcinoma on situ or suspicious in the prostatic urethra, I'll get biopsy from prostate urethral prostatic urethra biopsy. Then inserted the 3-way catheter by manual examination. Then if the patient stable no gross hematuria, I give him mitomycin C for 40 milligram in 50 normal saline if there is not contraindication such as perforation or gross hematuria.
The dose can be 40 milligram in 40 ml normal saline. Nothing wrong in saying 50 ml, but just check it out to make sure you're confident in that. The tumor is present lateral to left ureteric orifice. Do you want to take any precautions? What you may be expecting?
I'm afraid that there is a jerk. I'll discuss with the anesthesia to give him deep anesthesia. If he prefer there is comorbidity and he prefer spinal anesthesia, I'll discuss what to give him pudendal block or perineal block.
Okay, so while saying that, instead of deep anesthesia, the correct word is muscle relaxation. So you need a general anesthesia with complete muscle relaxation. That is the best way to prevent that. And patient can go for spinal, but again, we need to be careful. Spinal is not completely protective from the obturator jerk. You can bring in few things in this question. You can ask the anesthetist to do an obturator nerve block. You yourself can get trained and do obturator nerve block yourself. When you're doing the resection, keep the bladder not overfilled, so the bladder is not expanding and touching the obturator nerves in the posterolateral area. Use a little bit smaller loop rather than the large loop, and use the current sitting on the lower end so that you are not producing a lot of current to pass through the bladder to the extravesical space. Use a bipolar energy source so that the energy is looped inside rather than the monopolar. So avoiding obturator jerk is a very good question. I wish your answer to be a little bit more explanatory. Good. So this patient, you are arranging a CT scan. The CT scan showed no evidence of any distant metastasis. The patient's histology came as grade 2, high grade PTA, TCC of the bladder. No muscle included in your TURBT. So how are you going to proceed further?
BTA, high grade or high grade?
High grade, yeah. So in this situation, you should have a pen and paper. In the actual exam, when the examiner is saying, you should start writing. So whenever there is values like PSA value or any IPS score or the renal lesion size, width, etc., any values, any of these things, start writing. For example, if you have a pen and paper now, and if you start writing when I'm saying, you won't ask again. It's not bad. If you need to ask, but it's always good that you're not asking the examiner again. Examiner should feel, oh, okay, he's very attentive and he's taking down and not asking again. So it's G2, high grade PTA, TCC of the bladder, muscle not present in the specimen.
Okay, as this case muscle is not present, there is a chance of there is residual tumor in the bladder, and there is upgrade of a tumor. So I'll discuss this with the patient and discuss the need read UR after 6 weeks as a nice guideline recommended.
Okay. Do you aware of any specific studies which help us to make decisions for patients coming with visible hematuria? Or is there any other studies which can help us to improve the quality of TU or BT?
I can't recall now.
Okay, good. So if you don't know, that's the best answer. Say it, think for maybe 20 seconds, but say it quickly so that you won't waste your time. At this point, for this scenario, I wish you to read two studies. One is identify study. The other study is resect study. Identify study is for evaluation of patients presenting with visible hematuria. There are three categories, one for visible hematuria, the other one for non-visible hematuria. So other one is a retrospective study where they are reading the patients who had TURBT or known bladder tumor, but no past history of hematuria. Identify study is a UK-based study run by the BURST, B-U-R-S-T, BURST organization supported by BOWS. So they have released various guidelines on what is the chances of finding the bladder TCC in a patient presenting with visible hematuria. Those findings were almost similar to the Kadra et al. Study belonging to 1990s. And say, for example, visible hematuria, the chances of bladder cancer is almost like 24%, and chances for upper tract cancer present concomitantly in a patient with a bladder cancer is like 1.2 or 1.6%. So these values are almost same. The main advantage of Identify study is it has released an Identify calculator, which is available as a phone app, smartphone app. So in that app, if you enter the criterias like male, female, age, visible hematuria, past history, smoking, etc., it will give you the projected percentage of finding a cancer. So that will be very useful for you to counsel the patient. The second study which you can bring, sometimes examiners may not ask, but if you bring the studies, it will really fetch you very, very good marks. The second study in this context is known as resect study. Again, it's a study done by BURST, B-U-R-S-T, and supported by BOWS organization. Research study looking at the outcomes of TURBT. They have produced a clear-cut TURBT template protocol. By following the template protocol, the efficiency of TURBT will increase, the completion resection, making sure the deep biopsies are taken for the presence of muscle, and making sure the documentation is happened appropriately in a template fashion. And also there is a diagram, a bladder diagram available to draw the site size of the tumor so that the patients coming for TURBT will be better addressed. So the second study is resect study. The data collection is still going on. Possibly, I think if I'm correct, we have finished the retrospective data and we are going for prospective data collection. We'll be knowing the results later in 2023. So identify and resect, I wish you to bring it to the discussion. Sometimes examiner may not ask you, but you should bring it to the discussion. Okay, so your patient is undergoing the second resection as per the guidelines for absence of muscle in the TURBT specimen. The second resection shows presence of normal tissue and muscle present, muscle not involved, no evidence of any residual tumor. So how are you going to treat this patient further?
This this patient has a nice guidelines at intermediate category, so I'll follow him in I'll give him 6 cycle mitomycin. Then I'll follow him by cystoscope at 3 months. Then I'll set the side.
Why do you say he belongs to intermediate category?
This higher grade BTA, I think.
Okay. What is mitomycin? How it acts?
Mitomycin is anti-tumor antibodies. It's kills the floating tumor, and it's cross-linked DNA factor.
Do you know any methods by which we can improve this mitomycin efficacy?
By hyperthermic mitomycin. This inserted this machine inserted catheter to check temperature, not increase the temperature, but not damage to bladder and urothelium.
Yeah, so we are using a catheter and we are producing a heated mitomycin. The catheter tip has the temperature sensitive sensor, so that we are preventing unnecessary bladder mucosal damage, but at the same time we are delivering the mitomycin at a higher temperature. Any other methods available to improve the mitomycin delivery?
There is electromotive mitomycin.
Do you know how it works?
This I can't recall now.
Yeah, again, you need to bring the electromotive also yourself rather than examiner asking you again. By electromotive, the patients are given electric potential in the anterior abdominal wall. Because of the difference in the electric potential plate in the anterior abdominal wall and the posterior abdominal wall, that difference in electric potential makes the mitomycin to penetrate more and act better. It is available only in the specific centers. It's quite a highly specialized one. They are good for people who have tried mitomycin but failed, but at the same time not a very ideal candidate for BCG. That's where it happens. Okay. Okay. This patient had 6 weeks of mitomycin. Then what is your plan?
Then after 3 months, I will do. I'll follow the patient by urine cytology and examination and cystoscope.
Okay. In 3 months, everything is normal. What will you do then? Cystoscope, everything is normal.
I'll follow him after 6 months. If normal, then after 9 months, then after 18 months. If normal, then discharge.
Okay, so this is the middle path between the high risk tumors and the low risk tumors. In low risk tumors, you will have follow-up cystoscopy in 3 months and 9 months, which means like 3 months and 12 months from the first day, and then you can discharge if everything is normal. For high risk tumors, you will be following even up to 5 years. For intermediate, you need to tailor according to the individual patient. The examiner will accept the answer what you said. Well done. I'm happy with your quality of answers. There are a few things you need to be a little bit more aware of. Any questions you have in this scenario before we go to the next candidate?
Should I tell him according a nice guideline?
Yeah, you can tell. Always it's nice to bring according to NICE guidelines, or at least in one place according to EAU 2022 guidelines. It's nice to bring them. Yeah.
Thank you.
Okay, good. So you can mute and you can unmute if you have any questions after I finish with Yuvraj. Yuvraj, you happy to start?
Yeah, yes, please.
Good. So you are seeing a new patient You are a specialist lower tract oncology surgeon in your unit, and you are sitting in an MTT. Patient's histology came as G3PT1, TCC of the bladder, muscle resected present in the specimen, but muscle not involved. No evidence of any other CIS. Patient is a 52-year-old lady, previous smoker, but otherwise quite fit and well. So since you are a lower tract specialist, the patient is now attending your clinic for the histology discussion. How are you going to discuss that?
Since it's an MDT meeting, I'd like to get the complete histology report. In addition to the grade and the absence of any involvement of the muscle, I'd like to know whether there was any presence of any CAS, any other tumors, the total number of tumors, and whether they were completely resected. So the MDT discussion would be, since it's a T1 G3 tumor, there would be a need for a re-T or BT, since the chance of finding a residual tumor and the chance of upstaging the tumor is quite significant in this. So the chance of finding a residual tumor would be as high as 20%, and chance of upstaging the tumor is close to 30 to 35%. So I like to plan for a re-T or BT in the MDT and then take it up to the patient.
Okay. Is there any other way you can institute a treatment early and also maintain the RT or BT also? Is there any other possibility? Because patient is now diagnosed to have quite a high risk tumor. By waiting for RT or BT in 6 weeks, you are just sitting without doing anything, isn't it?
Yeah, so
I think this one is more of practical advice you may not have come across. So what you're saying is correct. But if you look at the other aspect, patient had complete resection, there is no sense of any incompleteness. Patient has muscle resected, muscle is free of the tumor. So if you are just sitting on a patient with a histology G3PT1, not doing anything for 6 weeks, there is a good possibility in 6 weeks when you do RT or BT, everything may be normal. And then if you want to restart some treatment, everything is delayed by more than 2 months or 2.5 months. So that's not a very safe one. So
probably we can start
correct. You can tell the examiner that whatever treatment you want to start, you can start. After the treatment, I will arrange a GA cystoscopy and biopsy to make sure that the treatment started is working well and there is no residual or recurrent tumor. If the primary histology is showing any signs of incomplete resection or the muscle not present in, but it's G3PT1, then you are correct. You need to go for repeat T or BT. You don't have to wait even for 6 weeks. You can even go for 3 weeks early, 4 weeks resection. Okay, happy with that?
Yeah, okay, thank you.
Good. So patient needs GA cystoscopy, but you are going ahead with treatment. What treatment you are going ahead?
I'd like to start a intravesical BCG for the patient. So the regimen would be consist of an induction and a maintenance course. Induction, it's basically a LAMPS regimen consisting of 27 doses. The induction course is a weekly dose for 6 weeks, followed which a check cystoscopy will be done. And if the findings are satisfactory, then I would like to continue with the maintenance course, which is a weekly course at 3 months, 6 months, and then every 6 months for the next 3 years, if the patient is tolerating the BCG well.
Okay. Before finishing this this particular question, you need to bring in 2 things. One is you will be accompanied by the urology cancer specialist nurse. And second thing is patient, I said, is a smoker. So you will be counseling the patient to quit smoking completely. You can even tell the patient that smoking could be the predominant reason for this bladder cancer, so that the patient will be quite cautious and stop the smoking. So you should use this clinic opportunity to discuss these 2. If you bring in these 2, that will really fetch you very good marks. Good.
Sure,
so you are starting with this BCG regimen. How BCG works?
BCG is basically a immunotherapeutic agent. It acts by getting imbibed or endocytosed into the urothelial cells through the fibronectin receptors of the urothelium. And once inside the urothelial cells, it initiates cell-mediated immunity. And by recruiting more of cytokines such as IL-6 and IL-8, it initiates an anti-tumor response in the body, thereby acting to destroy the cancer cells in the urothelium.
Okay. After finishing the patient's BCG induction, you are planning for a GA cystoscopy and biopsy, as we discussed. What are all the ways by which the BCG failure can present? Like, for example, BCG relapse, BCG failure, BCG resistant. How will you define them?
BCG failure is defined as a progression of in a non-muscle invasive bladder cancer to a muscle invasive bladder cancer. BCG relapses, the patient would have had a completion of the BCG treatment and would have responded well, but there will be a recurrence of a new bladder tumor, which is after the initial good response. And BCG refractory is a progression of the disease to a higher grade, either during induction or during early maintenance.
Okay. Your patient, after completing 6 weeks of BCG, after 2 weeks of completion, developed significant storage symptoms, frequency, urgency, getting up frequently in the night to pass urine. So what is happening? How can you help him?
This could either be a urinary tract infection in the patient, or it could be due to a reaction to the BCG therapy. So I like to get a urine dipstick, and if it's suggestive of infection, probably a urine microscopy and culture. If the culture comes as positive, I like to initiate the antibiotic course according to the culture sensitivity pattern. But if the culture comes as negative, then it's most probably a reaction to the BCG, which is administered intravesically. And this patient has to be treated symptomatically. If the patient is having symptoms of psoriasis symptoms, and probably I'd like to start the patient on an anticholinergic for a period of 4 weeks, and then review the patient and observe for the cessation of symptoms or decrease of symptoms.
Okay. So let us assume patient has got a positive urine culture. Is there any precaution you will take while choosing the antibiotics to treat the UTI post BCG?
In a patient with a history of BCG therapy or with the following BCG therapy, it's advised to avoid fluoroquinolones, which is ciprofloxacin or norfloxacin.
Why?
The
Why is that?
fluoroquinolones, it tends to interact with the BCG treatment.
How it interacts?
Sorry, I can't recall the exact mechanism.
Okay, so BCG is nothing but live attenuated tuberculi bacilli. So ciprofloxacin or any fluoroquinolones are part of anti-tuberculous treatment. So any anti-tuberculous antibiotics, if they are given for positive infection during BCG treatment, they will work against the BCG bacilli, and it's a live attenuated one. So obviously your BCG efficiency will come down. So you should use non-fluoroquinolone based antibiotics if the infection is positive. If the patient has BCG cystitis, you can treat as simple as storage symptoms for anticholinergics or beta agonists like mirabegron. If the patient has any voiding symptoms, you can go for tamsulosin. And in case if the patient developed florid BCGosis, like with axillary lymph nodes, what will you do?
So the general condition of the patient is to be established. If the patient is not in sepsis, if it's only a BCGosis, then the treatment should be initiated with INH for a period of 3 months.
Okay, so that is one thing. So at the time, if you are maybe starting on anti-tuberculous regimen, and patient may even end up taking ciprofloxacin. So there are some areas where you will give ciprofloxacin also as a part of anti-tuberculous treatment. There are some areas you will try to avoid to maintain the potency of the BCG. Okay, so this patient has completed the induction and follow-up cystoscopy and biopsy under anesthesia, showed normal bladder tissue and some scar tissues with some inflammation. So how are you going to further plan his treatment?
So the patient should be on a follow-up cystoscopy. If there are no lesions even after a maintenance course, the patient should be put on a follow-up cystoscopy, and if possible, cytology evaluation on a yearly basis for 5 years.
What about your BCG regimen?
I think you said the induction maintenance has been completed.
No, induction is completed, I said. So what is your maintenance regimen?
Yeah, the maintenance regimen. We have to start the maintenance regimen. The maintenance regimen is starts as a weekly dose at 3 months, 6 months, and then every 6 months for the period of 3 years.
Okay. And your patient is continuing the BCG maintenance dose. He's having the follow-up cystoscopy, as you said. He comes with a torrential episode of visible hematuria after 2 years, and you are arranging a flexible cystoscopy which showed a large recurrence in the right lateral prostatic lobe. Patient is undergoing TRBT, and TRBT shows G3PT2 PCC of the bladder with muscle invasion, high grade G3. So how are you going to counsel him?
I'll discuss with the patient in the presence of a cancer specialist to reveal the newer diagnosis, saying that like the tumor has invaded into the muscle, and therefore the patient needs to be treated with the radical treatment in the form of radical cystectomy with possible neoadjuvant chemotherapy. And the patient will need a urinary diversion, either in the form of either abdominal diversion or urethral diversion, and prolonged follow-up also.
How will you decide which diversion to choose?
First, it'll be the patient's. I'll discuss all the available diversions, namely the abdominal diversion, or the urethral diversion. Then I'll discuss the patient about the procedure, the complications, and the risk associated with it. First, it will be the patient's discretion, and the next thing would be to check for the presence of any renal impairment or liver impairment, liver disease in the patient. In the presence of any renal impairment, then urethral diversion or orthotopic neobladder is to be avoided. As well, if there is any other bowel issues like chronic inflammatory bowel disease or previous history of radiotherapy, then also neobladder is to be avoided. I'll prefer a ileal condy or abdominal diversion.
Why in renal failure patients neobladder is avoided?
Neobladder is basically a storage system for the urine. Therefore, the more the time the urine is stored in the neobladder, more will be the disturbance in the electrolytes and the creatinine levels. More amount will be reabsorbed and will result in further impairment of the renal function. Whereas in ileal condy, it's only a transit passage, so the disturbance in the electrolytes and the serum creatinine won't be as severe as in a neobladder.
Good. That's very good, because bladder will not reabsorb the excretory material like creatinine and other things, urea, while neobladder bowel surface is for absorption, especially small bowel. So it has got the absorptive capacity. So if the patient has renal failure, there will be more reabsorption of the excretory material, and patients will have accumulation of more renal failure. If the patient's kidney function is good, even then the neobladder is causing reabsorption of urea and creatinine, etc. That will be excellently handled by the normal functioning kidney. That's the main reason. And is there any reason you need to mention about patient needs to have hand dexterity to do intermittent self-catheterization? Because neobladder won't empty automatically. Patient needs to learn that. And how will you select the neobladder and how will you reconstruct it?
The neobladder, the most commonly used neobladder is a pseudo neobladder, which consists of a reconfigured ileum. So 50 centimeter of the ileum is the distal ileum is selected, leaving behind 10 to 15 centimeters from the ileocecal junction, so as not to disturb the absorption of B12 and other nutrients. So the isolated segment of the ileum is refashioned and anastomosed to the bladder with distal 20 centimeter fashioned out as a chimney to which both the distal ureters are anastomosed.
Okay, so how will you follow up a patient with neobladder?
The patient has to be followed up with a regular evaluation of the renal parameters, namely the creatinine and the urea and electrolytes to look for any electrolyte disturbances, and to make sure that whether the patient is emptying the bladder regularly with CAC, as neobladder will not be emptying completely per se. And there will also be increased mucus discharge, which can result in occasional urinary block or difficulty in CAC or intermittent catheterization. So that has to be explained to the patient beforehand.
Okay, so unfortunately, as you mentioned, your patient recovered well, but has significant mucus, which even sometimes causes a kind of a near retention episode, and the patient has difficulty in emptying the bladder with a catheter because of the mucus plugs. Any advice you can give for this situation?
The patient can be started on sodium bicarbonate, 1 gram daily. So this is known to decrease the incidence of mucus discharge from the neobladder, and thereby result in elevation of the symptoms.
What are all the complications patient may have if he undergoes for ileal conduit diversion?
The complication can be either early or late complications. The early complication can be a infection, urinary leak, or any anastomotic leak. The late complications can be a stricture at the ureteroileal anastomotic site, or it could be a leak from the stoma, or it could be a retraction of the stoma. It can have a parastomal hernia, or and there could be complications because of the bowel anastomosis also, resulting in gastrointestinal issues.
And what is the role for chemotherapy? We haven't discussed any chemotherapy. We diagnosed a muscle invasive bladder tumor. Is there any role
Sorry.
for neoadjuvant chemotherapy? Or
Yeah, the patient should be started on a neoadjuvant chemotherapy, which is a cisplatin-based regimen. Either it's a GC regimen, gemcitabine cisplatin, or a MBAC, which is a mitomycin, vinblastine, adriamycin, and a cisplatin regimen. If the
what
patient has not
precautions
been
you
given a
will take?
neoadjuvant chemotherapy, then probably post radical cystectomy, the patient can be started on a adjuvant chemotherapy.
Okay, what precautions you will take for chemotherapy? What parameters you will look for?
Patient renal parameters and the liver function test should be done, and both should be within the limits, because cisplatin is known to cause renal impairment. So if there is any diagnosed renal impairment, then cisplatin has to be replaced with either carboplatin or any other drug for the same.
Yeah, it's like cisplatin is excreted by renal mechanism. So normally the
Okay.
drugs were excreted by liver mechanism or renal mechanism. So we need a good renal mechanism to be there for appropriate metabolization of cisplatin. Otherwise, it will result in accumulation of the chemotherapy, which is not good for the patient. It is not that cisplatin directly going to cause a renal failure. We need good renal function for appropriate cisplatin metabolism. Um, can you explain the differences between choosing neoadjuvant chemotherapy and patient directly going for surgery and having chemotherapy post radical cystectomy? Pros and cons.
The advantage of having a neoadjuvant chemotherapy is the first thing, the patient would be in a good performance status to withstand the side effects of chemotherapy, and there will be a tumor downstaging resulting in complete resection with better oncological control. Whereas the disadvantages would be there will be a time delay between the point of initial diagnosis to the point of actual surgery, which is done for a curative intent. And post radical cystectomy, there could be a decrease in the performance status of the patient, which can result in difficulty in tolerating the chemotherapy.
Do you have any regimens to improve the recovery of the patient who is undergoing radical cystectomy?
While during initial evaluation of the patient should be made to undergo a cardiopulmonary exercise test, also a CPEX test, and enhanced recovery after surgery protocol has to be initiated. It's a ERAS protocol has to be initiated.
You should be explaining the patient with the Bowes information leaflet,
Yeah,
explaining
sorry.
the long-term complications, including the possibility of 1 to 3% of mortality in the perioperative period, like DVT, pulmonary embolism, need for secondary procedures, hematoma, anastomosis breakdown, secondary infections. You need to expand a little bit on it. Explain the enhanced recovery protocol.
Enhanced ERAS or enhanced recovery after surgery protocol is a multidisciplinary, multimodality treatment. It consists of a series of regimens, which is aimed to increase or early recovery of the patient after surgery. So it starts with increase having a good pulmonary initiating incentive spirometry preoperatively, and to decrease to start early oral feeding after surgery, to mobilize the patient early after surgery, and to initiate DVT protocols like stockings or or prophylaxis if needed.
Okay, this particular answer could be much more comprehensive. You can divide them into like preoperative, intraoperative, and postoperative. So preoperative, patient will be seen by the enhanced recovery protocol nursing team. So they will optimize the patient's, say, HbA1c, glucose, explain the patient what is going to happen on the day, send all the blood parameters so that we know what is happening, send the urine sample for culture to rule out any acute infection ongoing in the background. Intraoperative, patient will be avoided pre-operative night admission. Patient will be brought, if possible, on the day of the morning. And pre-operative, you can also include the anesthetic assessment, respiratory or cardiovascular consultant assessment if needed. So intraoperative on the day, patient early morning admission and nil by mouth, say for example from 12 midnight, there is no need for any bowel preparation as such. And unless if there is a neobladder reconstruction, we need to be preparing the bowel. And patient should have 100 milligram of glucose given early in the morning, which will help in preserving the aerobic mechanism and prevent unnecessary patients shift to anaerobic mechanism of metabolism. And doing the surgery like first in the day, and making sure that there is appropriate ITU bed or appropriate post-op surgical bed is available. Handling cell savers if necessary, quite rare, but it's a good way of using the hemoglobin which is lost. Making sure that the nasogastric tubes and drains were not placed unnecessarily. We definitely need at least one drain, but nasogastric tube can be avoided. Catheters are placed appropriately. Patient has got enough VT prophylaxis like enoxaparin prescribed, and the compression stockings were applied accordingly. And post-operatively, patient will be advised on early mobilization, trying to make sure he's getting the enoxaparin injections regularly, which should be continued for 4 weeks. Even if the patient goes home on third day or fourth day, patient will take the enoxaparin injections and you can do a self administration as a DVT prophylaxis. And making sure that if the nasogastric tube is placed, it should be removed as quickly as possible. Oral feeds are started as soon as possible. There is an evidence to say that we can start sips of water and liquid feed even when the patient is not opened the bowels. A faint bladder or bowel sound is enough. We can start the liquid feed. We can make the patient free of nasogastric tube. Appropriate removal of the drain within 24 to 48 hours. Appropriate discontinuation of the antibiotics if it is not necessary. Post-op pulmonary exercises to maintain the pulmonary volume. And also it is a good way of patient going within 24 to 48 hours to prevent nosocomial admissions, DVT, pulmonary embolism, etc. Quick hospital discharge. And ERAS nurses can give the patient like ring in 1 week time to see how he is doing. And the patient will also have a contact number for the ERAS team. Okay, it's a very comprehensive answer. I don't want you to repeat everything what I said in the exam, then that becomes a big component, but I wish you all to know so that in the exam you will be well equipped to answer correctly. Okay.
Thank you. Thank you.
Good. So I think both of you did very well. We started with a simple hematuria clinic setup. We did superficial bladder cancer, muscle invasive bladder cancer, mitomycin, BCG, radical cystectomy, chemotherapy, and ERAS. So we've completed the full setting. Any questions or doubts in bladder cancer?
Doctor,
Yeah.
Mr. Anand, if there is BT1 grade 3 patient, do we need to do a new adjuvant chemotherapy before?
That's a very important sentence. I'm waiting for what you're going to say. Are you going to say before radical cystectomy?
Yeah.
No, BT1, there is no need for radical cystectomy straight away. So
not if indicated, if
yeah, I will answer it. I understand your question.
Okay.
So what's happening is PT2 muscle invasive tumor, we need to do radical cystectomy. There is no doubt in it. For other non-muscle invasive tumors, but high risk patients, like for example, CAS or recurrent CAS or BCG failure or G3PT1, as you said, yes, there is a role for radical cystectomy. It's I'm not saying no, but not necessarily as a must. You need to present radical cystectomy as one of the option. And if the patients are happy with that, we can go ahead with radical cystectomy. But most probably patients will always wish to preserve the bladder and they will always wish to give a try for BCG. But the same patient G3PT1, if they have already tried BCG and if the BCG is failed, I think unfortunately we are heading towards the radical cystectomy. Regarding chemotherapy, yes, your question is very valid. Oncologists are not interested in giving chemotherapy if there is no muscle invasion. So we can go ahead with radical cystectomy without neoadjuvant chemotherapy. In the bladder resected specimen, if there is any muscle invasion, unfortunately, then patient will need a post-op chemotherapy. For neoadjuvant chemotherapy, oncologists prefer presence of muscle invasion. So that answers your question. Okay.
Thank you. Thank
Yeah. Sometimes
And,
if you're not able to get appropriate muscle biopsies to prove muscle invasion, but the CT scan shows a definite muscle invasion, extravesical spread, something like that, then the oncologist may be happy. But they should have some evidence of muscle invasion for chemotherapy.
Okay.
There are a lot of institutes even in UK where they directly go for radical cystectomy even for muscle invasive disease without neoadjuvant chemotherapy for the same reasons what Yuvraj has mentioned, to prevent delay. Patients are in excellent performance status. They don't want to have neoadjuvant and operate radical cystectomy on health compromised patient, etc. But in ideal world, neoadjuvant chemotherapy is very good. There is the study you can quote is Advanced Bladder Cancer Study, ABC study, which clearly proved the role of neoadjuvant chemotherapy. Any other questions?
And regarding lymph node dissection, what should we mention? Should be a standard lymph node dissection or an extended lymph node dissection for the
Yeah,
muscle
the
invasion?
normal standard lymph node dissection, including obturator nodes, external iliac, internal iliac, up to bifurcation of the common iliac and presacral is enough for all the patients. But in case if the patient preoperative investigation shows any presence of M1A, which is like, N1 or M1A, whatever, then you have to go for extended lymph node dissection. There is a role for going up to bifurcation of aorta or even up to para-aortic nodes from the branching of the inferior mesenteric artery. But if it is beyond that, then it's better to do a neoadjuvant chemo and then see how the lymph nodes are responding before taking it forward.
Should we do a repeat of imaging after neoadjuvant, or you can directly proceed to a radical cystectomy?
There is a role for example, if there is no lymph node spread, if you are discussing muscle invasive organ contained tumor, there is no point in repeating the imaging because you're not going to learn anything new. But if there is a residual tumor after the TURBT, before when the patient is going for neoadjuvant chemo, if there is a residual tumor, those or lymph nodes, those patients will need repeat cross-sectional CT scan imaging, which will tell us about the clearance of the bladder residual tumor and also response to the lymph nodes, and also cystoscopy, just to local anesthesia flex cystoscopy, just look into the bladder for absence of obvious residual tumor. Because if there is a residual tumor post neoadjuvant chemotherapy, it's better to know that, because after radical cystectomy, we are blinded. We are giving a chemotherapy, but we don't know whether that particular patient is sensitive to that particular chemotherapy, but we are giving post-op chemotherapy without knowing that. So neoadjuvant chemotherapy gives you a very good window to know whether that particular GC or MVAC regimen the patient is sensitive to, patient's cancer is sensitive to.
Okay, thank you.
Okay, guys, it's exactly 61 minutes. We always wish to have a class for 60 minutes. Any other questions or doubts before we complete today?
Thank you.
No,
Thank
thank
you.
you. Thank you.
Good. If there are no other questions, I don't think I can make a session tomorrow because my on-call is slightly on the busier side. But I think Sunday I may have some breathing space for a class. So there is a small possibility UK time morning, like 11 o'clock, 10 o'clock, before 12 o'clock, I will try to message in the group so that you both can join or anybody free can join. But Monday, definitely we'll have a class. Monday class is definite. Sunday, we'll give a try. What topic you want to discuss next?
Prostate cancer.
Good. Good. That's it. You can do only one topic at a day. So prostate cancer, prepare everything right from scratch. We will do it on Sunday between in the morning, like 10 o'clock to 12 o'clock, 1 hour. I will tell the correct time based upon the on-call. If I got stretched up on Sunday, we'll do the class definitely on Monday. Okay?
Okay, thank you.
Good. Glad to speak to you both, and wishing you a nice holiday weekend. Spend some good quality time with your family also.
No, Mr. Anand, you want to
Sir.
discuss about the stay or venue or something? You were saying like.
Yeah.
Hello.
Hello.